So this is a talk that is very near and dear to my heart, and I also think we'll try to keep it informal, a little bit fun, because as most of you know, ketogenic diets are very much in vogue, they are very much in. So I thought it's best to begin with just a flow. So I will speak about what is the rationale behind this, bring you back to school, I apologize for that, and understand ketone body physiology. Cannot talk about all the benefits, so I'll focus on weight, metabolic syndrome, and diabetes. Of course, every study comes with a caution, and then at the end, I will show you results from our center for what we have an ongoing small study along with a case that we can take a look at, and that will stick in your mind, hopefully. So what is a ketogenic diet? As you've heard this morning, we have intermittent fasting, we have eat breakfast, do not eat breakfast. Similarly, we have several diets now looking at macronutrient composition. So as you know, our diet mainly consists of protein, fat, and carbohydrate. So similarly, the Ornish diet, which came back in the day, was a different kind of diet. A standard American diet, not very different from the Indian diet, has about, so on the y-axis you have carbs, on the x-axis you have protein. This does not have fat in it yet. So on the standard American diet, you have kind of 50% carbohydrates. A Mediterranean diet, which from the Predimed study, as we know lately, seems to be one of the healthiest diets, and that has a good mix of balanced carb and balanced protein along with the good fat. Along with the paleo diet says go back to your ancestors, what Bansi was telling you, go back 200 years and eat like our ancestors used to eat, lots of vegetables, fruits, nuts. And then we get into our well-formulated supervised ketogenic diet is what I urge the audience to walk away with. It's not going to be an unsupervised diet. The key factor here is your carbohydrates go down. Now this is what these are our typical meals from the four corners of our country. So as you can see, whether it's a Gujarati thali, a Punjabi thali, it's more than 60 to 70% carbohydrate. Protein is very minimal, fat is very minimal. Similarly, a South Indian or an Eastern meal, the majority of our diet consists of carbohydrates. And again, this is from a very well done study from our country. We know from the START study that this is true for our country and very reflective that 60% of our diet is carbohydrate, protein constitutes about 20%, and fats are about 15 to 20%. So is this a balanced diet or not? How does this work? Why is this causing this increasing epidemic of diabetes? So I now present to you what we know is the sine qua non or the hallmark of type 2 diabetes, insulin resistance from the point of view of a carbohydrate. So what is the carbohydrate thinking? So we know insulin resistance leads to hyperglycemia and hyperinsulinemia. This insulin resistance is at the level of the skeletal muscle, at the level of the liver primarily, whereby the skeletal muscle fails to clear the glucose and the liver fails to turn off its hepatic glucose production. Now let's go over here, follow me along. So once you eat carbohydrates, if you eat the right kind of carbohydrates and a good amount of fiber, as you heard from my two prior speakers, if you calorically restrict yourself, as you just heard from Shilpa, what is going to happen? You will follow the path to health. You will open your GLUT4 transporters and you will store some as glycogen and use the rest for ATP production. If you eat too much, too frequently, too many times, and too little fiber, what you're going to do is you are going to overwhelm all these mitochondria that Shilpa was talking about, and what is going to happen is you will stimulate de novo lipogenesis, and you will now start storing excess glycogen, which is then converted to fat, and this is your visceral fat. This is your fatty liver. This is your pancreatic fat that Shilpa talked to you about in the direct trial. Therefore, truly speaking, an overwhelming amount of carbohydrate is equal to a carbohydrate intolerance. So we will today look at insulin resistance from the point of view of carbohydrate intolerance. This theory comes also from Dr. Jeff Volek's lab, and I can guide you to this wonderful paper. So what is a ketogenic diet? For the audience here, as I showed you, this is what your normal diet looks like. So as you can see, about 70% carbs, 10 to 15% fat, and protein about 20%. When you switch over, so what we are going to do in a keto diet, we will stop or restrict your carbohydrate level down to about 10%. We will flip a metabolic switch. We are going to tell the body, so right now, why do we eat food? Just as Bansi said, in the morning you eat food because you need energy. It's like putting petrol in the car. It's fuel for your system. You need to make ATP. Right now, since 70% of your food is carb, what does that mean? That you're using carbohydrates as your source of energy. In a ketogenic diet, we will not show the body any carbs. So after 2 to 3 days, when your body uses up all the glycogen stored in the liver, it will now start looking for a secondary source of fuel because you still need fuel. And what it now does is it will mobilize the fat from your stored fat depots. It will start making free fatty acids, and this will be used and mobilized to the liver to make acetyl-CoA and then ATP. This is what is known as ketone body production. Your body switches from carbohydrate to fat metabolism. And this is what your diet typically looks like. So for a keto breakfast, most of my patients will hence make the big switch to eating sprouted moong, what we call a bulletproof, or a keto coffee or a keto chai. They will have an almond and flaxseed keto roti with some green leafy vegetable based with paneer in it for fat. This is a vegetarian keto diet, a very Indian keto meal with some snacks, with some Greek yogurt and paneer at dinner time. So what we are doing is we are trying to give them a vegetarian keto diet, because remember, protein is not the main source of energy. So this is how ketosis works, is when your body switches from glucose levels to make energy, it now switches and starts releasing your stored triglycerides. So in a cartoon form, you can see how ketones are used as a source of energy. And biochemically speaking, your mitochondria are the one that are now using this 2-acetyl-CoA to convert it and break it down and make acetoacetate, which is the major ketone, which is then converted in the circulation for transport as beta-hydroxybutyrate. Normally in our blood, we do not have any ketone bodies. In a ketogenic diet, you can see how the sugar levels drop. Insulin levels that we've been talking about, they go down dramatically, and your ketone body concentration rises, but never to the level of ketoacidosis. This is what nutritional ketosis means. We only keep them in a trace level, 2 to 3 micromoles per level, and not in the level more than 10, which is ketoacidosis. So there is strong evidence which tells you that not only does a ketogenic diet work on diabetes, weight reduction, pre-diabetes, and metabolic syndrome, but may also have benefits, of course, we know for epilepsy, cancer, PCOS, prevention of Alzheimer's dementia. I do not have the time to go into all of the discussion today. So I will focus on these 3 or 4 things which are of interest to us. The ADA diabetes guideline as of 2019 have now actually put this statement that for people with type 2 diabetes, where glycemic targets are not met, reducing overall carbohydrate intake with a low or a very low carb eating plan is a viable approach. So this is now a part of the guideline. So now let's look at this very recent trial, hot off the press. On June 20th, it was released. Dr. Volek's group took 16 obese participants with a BMI of 39. All of them had metabolic syndrome. Initially, they had a moderate carbohydrate diet run-in. Then they did a low carbohydrate. They were washed out. Then again, they were given a moderate carbohydrate. At the end, followed by a high carbohydrate. Here, a picture speaks 1,000 words. You can see at baseline, all of them have metabolic syndrome. On a low carbohydrate diet, so many of them have now no metabolic syndrome. When they are washed out, moderate carbohydrate diet, only 3 of them are able to reverse their metabolic syndrome. And on a high carbohydrate diet, only 1 person did better in terms of his metabolic syndrome. So you can see in terms of metabolic syndrome, a low carbohydrate diet does much better than a moderate or a high carbohydrate diet. Now what we always worry about, hence I put it over here from 2 large trials, the DELISH and the VERTA trials, looking at cholesterol. All my patients go, if I'm going to eat such high fat, we are not asking you to eat saturated fats. We are trying to say that you need to eat good varieties of fats. We are trying to give you things that have a good cholesterol. So your keto roti is an almond and a flaxseed roti. So what you can see over here is specifically looking at the cholesterol profile. As you can see that even though the total cholesterol, LDL cholesterol goes up, the HDL and the triglyceride levels went up. However, when we did a particle analysis, what we see is that the small dense LDL, which are atherogenic, that particle number goes down and the LDL particle volume and size increases. And this is not the atherogenic molecule. So for the most part, we have several other studies, and I'm not showing you all of those today. The VERTA trial is a very well done study, and hence I show you the results, that it does not seem to cause any harmful effects to your cholesterol. So do not be worried about that. And this is showing you a picturesque photograph from the previous study that, as you can see, this is baseline. This is a low carbohydrate diet. You can see the LDL particle size increases, and hence it's not the atherogenic molecule for you. So how about now comparing it to a low fat diet? So in this particular intervention, and this is a meta-analysis looking at low carbohydrate versus low fat diet, the carbohydrate in the low carb diet was not strictly ketogenic, it was 60 grams per day, but participants were actually able to keep it below 40 to 50 grams. And the difference in weight loss, as you can see, much higher weight loss to your left, favoring the low carbohydrate versus the low fat diet. From Dr. Yancey's study, we similarly see now in our type 2 diabetic patients, very low carbohydrate diet, mean A1C at the starting 7.4%, and after the trial 6.3%, with significant reduction in glucose lowering medications. This is the 12-month outcome of a randomized trial from Dr. Saslov group, and what she also shows you is that from a moderate carbohydrate versus a very low carbohydrate, the drop in HbA1c at 6 months, and now this is an advance. I'm trying to show you the sustainability of this diet even at 1 year, and we also now have some data looking at about 2 years that this effect can be sustainable and safely done in your type 2 diabetic patients. Which brings us to the very important question, is ketogenic diet the panacea? Can we reverse type 2 diabetes? Because we are now in the era with the direct trial to cause type 2 diabetes remission. So from the VERTA trial and from Dr. Saslav's study, what they found is using 200 patients and 85 patients, at the end of 12 months and about in both the groups, about 50 to 35% partial remission of diabetes was seen. So certainly renewed interest, we need Indian data, ongoing data, longer term data. Again, how hard is it to think that you can stick to this diet? I'm sorry, this is from Saslav's group again. Very low carb diet, low fat diet. Interestingly, patients are able to stick to the diet. So the adherence level was not poor, and hence it's very interesting to see this. Of course, a word of caution, headaches, weakness, fatigue. The keto flu is reported on day number 2, and we have to worry about these effects on lipid and bone in the long term. So then how long should you continue this keto diet? What should you tell your patients? Can they do it for 1 year? Should they do it for 2 years? Are they doing it to lose weight? Is a calorie truly when you're talking about good fat? So here is our trial. This is an ongoing study we have at our center. We currently have 22 patients with pre-diabetes and type 2 diabetes who have undergone a 12-week, what I now present to you, something known as a cyclical ketogenic diet. So in our intervention, what we are doing is, we initially, when the patients come in, we put them on pretty much a diet similar to what they are doing. There might be a slight change in the kind of carbohydrates they are using. Initial phase for 2 weeks, they do moderate carbohydrate, low fat. It's not a weight-losing diet, it's an isocaloric diet. Then they are taken into a ketogenic diet, wherein the carbs are reduced below 50 grams. Most of the patients in Gujarat are vegetarian, where I practice. So it's a hypo or isocaloric diet depending on their weight. And for about 2 to 3 weeks, we put them into a ketogenic diet, and then we take them and bring them back again into a low carbohydrate diet. And we repeat this cycle. So this is a 6-week program, which they have to repeat twice in a 12-week period. This is the preliminary results from our study. As you can see, just at the baseline at 3 months, their weight, which was almost the mean weight in Gujarat, if you can believe it, is 100 kilograms. And at the end of 3 months, we have a mean weight loss of about 7 kilograms. And the p-value is highly statistically significant. Of course, the same reflects in the BMI. How does this translate into glycemic parameters? The fasting blood sugar, as you can see, the mean fasting blood sugar, which was about 140 milligrams per deciliter, we see about almost a 36 milligram per deciliter drop with a p-value of 0.002, which is highly statistically significant. Similarly, for the HbA1c, which was roughly about 7.6%, it has dropped to the range of almost 6.1%. So we have a very strong correlation and a very good p-value less than 0.005. As I mentioned, this is an ongoing study, and hopefully we can now look at one of our patients who has completed 6 months. This is a 44-year-old main patient, type 2 diabetic for 18 years, so long-standing, CAD, fatty liver, erratic lifestyle. He's on every medication of diabetes except for a GLP-1 analog, and he's also on insulin. This is his weight, and his HbA1c is 9.3 kilograms. When he entered our study, this is his medications. As you can see, over the subsequent weeks, his medications really continue to drop down, and currently he's actually only on metformin twice a day. This is his weight progression over 6 months, from 126 kilograms to 99 kilograms on a cyclical ketogenic diet protocol. And his blood reports, as you can see, he has gone from 9.3 to 6.1. Liver enzymes, fasting sugar, cholesterol, everything has improved. And this is a gentleman, he's now training for a half marathon. So I bring you back to the pathophysiologic defects in type 2 diabetes. with hyperglycemia, insulin resistance. It's just the last slide. And therefore, again, I bring you back that now start thinking about a newer way, a newer approach to treating type 2 diabetes, not just with medications. And I'm not a dietitian, I'm an endocrinologist. So to tell you this is something, as a matter of pride that for my dietary colleagues here. Think of carbohydrate intolerance. Think of what diet we need. Is it pharmacogenomics, intermittent fasting, ketogenic? We don't have all the answers yet. Are you ready to make this switch is the question. It's difficult, but not impossible. And as one of my patients has this t-shirts when she's on keto, she wears this, keep calm and keto on. So thank you very much for your attention.